But it's like two fighting entities. We put them on stuff to stop all that, and they put them on stuff to get it going. So anyways, back to cardiology review. Did you guys have any questions on anything from the EKG stuff last week? Hopefully you guys were able to download it. It was, she made it available. You guys can download it and review all the rest of it. If you have any questions, let me know. But you got to do it in the same order. Rate, rhythm, access, check out the ST segments, the QRS, the PRs, all the intervals. If you do every single EKG that way and write down on a sheet of paper, you'll be fine. After the first few, we started just doing look for the important stuff. But if you do all your EKGs that way, you'll be fine. So anyways, cardiology review. I will tell you, you guys are going to be starting more rotation soon. The better you are at doing HMPs and consults, the better people will think you are as medical students. It has nothing to do with your clinical judgment or how intelligent you are, but the better you are at doing consults and HMPs and writing everything out and collecting information, the better you'll be evaluating, the better you'll do. So there's a website called historyandphysical.net. It has a very good explanation of how to correctly do an HMP, like an admission HMP, and how to correctly do a consult. People do judge you based on this, so make sure you guys know how to do this. Now, in cardiology and most of internal medicine, 90% of your diagnosis comes from the patient's history. Remember they taught you that in medical school at some point? Yeah, get a good history because you'll get the right answer, or you'll find out what the patient has. It's actually true. In cardiology especially, and I'm sure other fields as well. So if you get an accurate history of what the patient is here for and what they're saying, you will know what they have 90% of the time. There's no guessing and have to order any tests. I mean, you probably do at some point, but 90% of the time you don't really need anything. You would just order a test to confirm it. And that's how you should practice medicine. It shouldn't be guy walks into the ER, gets scanned, passes through a CT scanner, an X-ray device, gets blood work, and then shows up and the doctor talks to him. It's got to go the other way. You got to talk to them, see what they have, and then order a few things to confirm it. So in cardiology, a good exercise history is also very important. If a guy tells you, last week I ran the Chicago Marathon, and they come in this week saying, I have chest pain, they don't have coronary heart disease. At least not significant coronary disease. You cannot run for 5 miles or 2 miles, whatever it is, without any symptoms, and then today you have chest pain, and we think you have coronary heart disease all of a sudden. That's not really how it works. So if you can get a good exertional history or a good exercise history, you could pretty much rule out coronary heart disease almost instantaneously. If a guy tells you I run on the treadmill every day for 5 miles at a jogging pace, do you ever get chest pain when you do that? No. Do you ever get short of breath? No. Do you ever get lightheaded? No. They don't have anything. You can pretty much pat them on the back and say you'll be all right. Keep running on the treadmill. You send them home. There's no point to doing anything. So when it comes to chest pain, I always talk about the 3 P's of chest pain. If you can get the patient to say one of these things and describe their chest pain in one of these 3 ways, they don't have a heart attack. If you can get them to say it's positional, and what does positional mean? They lean forward and it feels better, but if they were to stand up, lay down, or arch their back, it hurts. That's positional chest pain. That is, you're pulling on all the ligaments and everything that holds the pericardium in place. So that's pericarditis. All right. If you can get them to say that and describe it that way, that's what they have. If you could get them to describe it as producible, all right, they can touch it and make it happen. If they say, yeah, I put my arm here and it hurts, or I move my arm in a certain way and I feel that pain right there, or I twist my, I'm doing like this, I'm stretching and I can feel chest pain. Well, if they can make the chest pain happen, it's not a heart attack, all right? If you can get them to describe the pain as something they can produce, or when you physically examine them, that you can produce it, it's not a heart attack. The other way you can get them, the last one is if you can get them to describe it as pleuritic. What is pleuritic chest pain? It's probably up there, right? Changes with breathing. So if they take a deep breath and that gives them the chest pain, it's not their heart, okay? It's something in the lungs, all right? And there's a lot of them. The good news is they all start with P. Pneumonia, pneumothorax, pleurisy, pleuritis, pericarditis, pulmonary embolism, pleural effusions, and rib fractures. I had to spell that one. So that's a P2, fractures. They all start with P. If they have pleuritic chest pain, it's definitely not their heart, and it's something else going on in the pleura of their lungs or something in their lungs. Now you'll notice that pericarditis is both positional and pleuritic. All right? So they'll describe it exactly like this. They'll say, I take a deep breath, it hurts, because when they take a deep breath, they're stretching out the same ligaments that hold their pericardium in place. So if they have pericarditis, that's going to happen too. So that's why that happens. Now you'll notice all of these can also have a fever. Every one of these can cause a low-grade fever. Just because they say a person comes in and has chest pain, they have a fever, it's not always pneumonia. Sure, if they have a really high fever and they throw in a productive cough and all that, yeah, it's probably pneumonia. That's what they want you to think. But all of these can give you a low-grade fever, so don't let the fever always be like the thing that tips you off. Even an MI, if somebody's really having a heart attack, they will have a low-grade fever. So get them to kind of, if you can ask, when you're first evaluating a patient, if you can get them to describe it like one of these ways, they don't have a heart attack. So how good is history? They did a study. They took all these people and everything they've said, and they looked at, well, did they end up having a heart attack or not? So it turns out, if it radiates to one arm or shoulder, if they describe chest pain that radiates to an arm or a shoulder, or both arms or a shoulder, it's 4.7 times more likely to be an MI than anything else. Now make sure that's really what they're saying. You know, it can't be, well, my neck hurts, and if I turn my head a certain way, I feel the stinging pain down my neck. You know, that's like a neck, cervical radiculopathy or something. So if they really say, I got this chest pain, and it hurts down my arm, and I feel it in my neck or shoulders or whatever, that's more likely to be a heart attack than not. And if they say associated with exertion, that is 2.5 times more likely to be a heart attack than not. These are the three most important things. Associated with exertion, and then radius to an arm, both arms, or a shoulder. All right? And they say, well, what made it better? Well, I sat down and rested, and then it got better. So improving with rest makes a huge difference. The whole thing about chest pain is it's an oxygen supply and demand mismatch. Anybody take economics? Any economic majors? All right, so maybe a few. Supply and demand. The supply needs more oxygen than the vessels can supply. So the demand and supply is mismatched. So whether that means you have blockages. When you increase demand by exercising, the supply is not going to get there. So that's when you get chest pain. That's what gives you chest pain, not enough oxygen or flow. So they looked at this. Now, you'll notice that described as pressure is really, really low. All right? If a patient comes in, they all teach us in medical, it sounds like an elephant sitting on my chest and chest pressure. That has nothing to do with MMI. It's very, very low down here. Asthma can give you a pressure sensation. Lots of things can give you a pressure sensation. So don't let the word pressure, patient comes in describing chest pressure, don't let that fool you into thinking it's an MI. They have to say something about exertion, radiation, those kind of things. And it's not always, you know how we ask them sometimes, does it feel similar to a previous MI? Well, that doesn't always correlate entirely. So don't let that kind of fool you. They also looked at how bad is history. All right? What can the patient say for us to decide this is not an MI? So there are lots of things. Pleuritic, positional, described as sharp. All right? If the patient says it feels like somebody stabbed me in this spot, all right, that's not an MI. It's not a stabbing, sharp pain. It's a very dull, achy pain that they really can't point to. You know how they say, if they point to it with their entire hand open, they go like this, they say, ouch, I got chest pain somewhere here, that's probably a heart attack. But if they can point to it with one finger and they say right here or right here, it's not a heart attack, that's pretty true. If it's a well-circumscribed area, if it's like a spot and they say it's right here, this little spot right here, less than 2 centimeters, and they can point to it, it's not an MI. If it's inframammary, if it's below their nipple line, it's not an MI. If it's not associated with location at all, it's also very low. So if you can get them to say one of these things, it's highly unlikely for this to be an MI. So if they describe it as lower than their nipple line, they can point to it, they can make it happen, it's really, really sharp. Now the other thing is, we get these people sometimes come in and say, I had chest pain for 5 seconds. Well, that's not an MI. Chest pain for 5 seconds, it could be anything. It could be muscles, could be your joints, whatever it might be, but it's not an MI. An MI has to last over 20 minutes, and it has to be, it got better with rest. If somebody comes in and says, ouch, I got this chest pain, it wouldn't go away, I tried to sleep it off, I slept, I sat down, whatever, and then it slowly got better. That works, all right? Or if it's more than 20 minutes, like I had it all day, and I was raking the leaves, or they were doing some kind of exertion, and it started coming on. That is angina. So you all know the risk factors, but I will tell you that the single worst risk factor is smoking. All right, nothing else incurs such a high mortality or such a high increase in cardiovascular disease. It gives you peripheral artery disease, it gives you coronary artery disease, aortic disease, carotid disease. All of these arterial diseases, all the arteries are connected. So you'll start having stroke, you'll start having peripheral artery disease, you'll have an aortic aneurysm, MI, all kinds of things. So the one thing I will stress to everyone, and I tell everyone this, every single patient that smokes or quit smoking, I tell them if you quit smoking, don't ever start again. But if you're still smoking, we have to find a way to quit this. And even if you gain 20 pounds, some people say, well, I don't want to quit because I may gain some weight. Well, fine. If you gain 20 pounds or 40 pounds, that does not give you as much risk as continuing smoking. So smoking, out of all the things that you could, of all the lifestyle modifications a patient could make, if you can get them to quit smoking, and even if they gain a little bit of weight, that is the best thing you can do for your patients. I don't know what fields you all plan on going into, but you got to try to get these people to quit smoking. And the rest of these you all know: diabetes, male sex, hypertension, low HDL, high LDL, all the usual inflammatory stuff. Or if they've had known coronary disease, they already had heart attacks, that's obviously not just a risk factor, they have the disease. So there are also things called risk equivalents, and we kind of touched on them. If they have carotid disease, if they've had a carotid endarterectomy, if they've had aortic aneurysm, peripheral artery disease, all of these things are equivalent to having coronary disease. If you've had a stent or an MI or a CABG, obviously you have coronary disease. Diabetes was added on there. If you have diabetes, you have coronary artery disease, without a doubt. And that has been proven, back in like early 2000. If you have diabetes, and we check everyone, we evaluate everyone's arteries that has diabetes, you have some level of coronary artery disease. The problem is we wait so long to tell people that they're diabetic, and we'll get into that a little bit later on. So the TIMI risk score, you guys I'm sure have heard of this. It's a way for the ER doctor or any doctor really to be able to tell this patient you're fine, you don't have anything. So you see, if the patient comes in saying they have chest pain, they get a point if they have every single, for each one of these they get a point. If they're over 65, they get a point. If they've been on aspirin within the last 7 days, they get a point. And the reason for this is, if you're already on aspirin and you come in complaining of chest pain, that's worse than somebody who's not on aspirin. That makes sense there. If you have diabetes, hypertension, cholesterol, any three of these risk factors, you get a point. If you've had known coronary artery disease, you had an MI already, you had a carotid endarterectomy, whatever it is, that all counts. 2 episodes of chest pain in the last 24 hours lasting greater than 20 minutes. So if you've had that, you get a point. Non-negative cardiac markers. All right, indeterminate troponin counts. Anything that's not negative. It doesn't have to be positive, but if it's not completely negative, you get a point. And the last one is any ST deviation, whether it's up or down. Remember last week we talked about ST deviations. Up or down counts. And it's 0.5. That's less than one of those tiny small boxes. So that counts too. So if your score is 0 to 2, your chance of having an MI, if we discharge them right now, their chance of having an MI in the next 30 days is less than 3%. The more of these you have, up to 6 or 7, you have a 19% having an MI or death. All right, now we got to be smart. We can't just use the TIMI risk score and say, all right, go home. If the guy comes in with 2 points, but it's positive troponin and ST elevation, are we sending them home? Tell them, I don't know where you're having an MI. No, they're clearly having an MI. They got to go to the cath lab and get opened up. So we got to use our brains. These are guidelines, and we can kind of use these to help us, triage and risk stratify patients. But we also got to use our brains. So now, you've all heard the term ACS, right? Acute coronary syndrome, what is ACS, what is it? So we're going to skip the unstable angina part, but we're going to go into the 2 kinds of MIs. So you have a STEMI, and you have a non-STEMI. These are the only 2 kinds of MIs. They used to call them Q-wave MIs and non-Q-wave MIs. Nobody uses that terminology anymore. All right, all that means, I put a Q over here. A STEMI is most likely to leave a Q wave on EKG. A Q wave is just a finding on an EKG. It indicates prior damage. So ST elevation MIs, 90% of the time will leave a Q wave. Non-STEMIs, 90% of the time, will not leave a QA. So don't use the words QA the mind, non-QA the mind. There is really no such thing. You'll sound like you graduated medical school like 40 years ago. It's called either STEMI or non-STEMI. All right? So STEMIs are pretty easy. Open the artery. We've got to get that artery open. If you look at the lumen of the artery, it's fully blocked. Whereas in a non-STEMI, there's some blockage, but there's still flow. Fully blocked artery gives you that ST elevation injury pattern on the surface EKG. All right? So these guys got to go to the cath lab. If you don't have a cath lab and you can't get them to 1 in 90 minutes, you give them thrombolytics. All right? That's pretty simple. And they need medical management. And this is medical management, and we'll get into it in a second. Non-STEMIs, they get medical management. All right? Now what is medical management? Please throw the word MONA out of your brain cells. I don't know why medical schools still teach the word MONA. They're, morphine, first of all, and we'll get into it, but it kills people. They've looked at the Duke registry, and we'll get into it. MONA, the morphine part of it, increases mortality by 48%, and in some studies even higher than that, and it causes the infarct size to get bigger. So take MONA out of there. If you want, you can make it BONA. You can put a beta blocker in there. All right? As inappropriate as it sounds. No. But this is medical management. And on step 2, they'll never ask you, they'll come in, they'll describe a guy with chest pain, he has ST elevations or positive troponins, whichever kind they're trying to describe. But they'll never have you pick between aspirin and oxygen. They may have you pick between, should you start on oxygen first, or ACE, or statin. But no, the whole problem is the oxygen supply problem, or the demand is too high. So what you got to do is give them oxygen. Aspirin, they got to chew it. Why do they need to chew the aspirin? Starts working right away. Starts working in 20 minutes instead of like 6 hours. So they chew it. It's like that, they call it baby aspirin. You shouldn't really be giving babies aspirin. But it's chewable. It's great. It's the Flintstones. But that's why they call it baby aspirin, because it tastes good and people to chew it. And then you got to give them clopidogrel. This is Plavix, 600 milligrams. See, aspirin and clopidogrel are antiplatelet agents. The problem is this inflammatory thing is happening. Platelets, fibrin, other clotting products are all starting to aggregate. So aspirin and Plavix block that. Heparin or enoxaparin, Lovenox or heparin, those also block the clotting cascade. They block ATP3 and they help you, they unbound thrombin won't bind. All right, we have some other agents now that can unblock bound thrombin, but that's not in the guidelines yet. The next one is a beta blocker. Why? You've got to reduce oxygen demand. If their heart is beating at 150 or 130, that's a huge oxygen demand problem. You've got to get them down to like 50. All right, so you keep giving IV beta blockers until you get their heart rate down to 60 or 55 or somewhere in that range. That reduces oxygen demand significantly. Now they tested, what if we give them a calcium channel blocker? Calcium channel blockers reduce the strength of the contraction, right? They looked at that. They said, well, if we can reduce the strength of the contraction, maybe that will reduce oxygen consumption. It didn't. It actually killed people. So we don't want to do that. You don't want a heart that's hypoxic to even be weaker. Okay, so we don't want that. We just want to slow it down. So beta blockers have an improved mortality benefit. All of these things improve mortality. None of the ones listed in this first column are neutral or will kill you. So these are the standard of care. All right. 2B3A inhibitors. These are like Integralin and Reapro. We don't use them right away anymore in the ER, but we use them in the cath lab. So the ER, or like you're a first-line responder, you probably don't have to worry about these. And I doubt they'll be on your test. A statin. You got to give them a torvastatin 80. But they're not going to probably ask you for the exact one. That's Lipitor 80. It's been proven that even in the acute setting, statins make a big difference. Now you may say, well, cholesterol is a lifelong problem. Why do I have to give them a statin right now? What do statins do acutely? Say it again. They stabilize plaques. They reduce the inflammation. The whole problem is the endothelium is inflamed and going crazy. They help the endothelium relax and chill out, and that whole inflammatory response gets halted. Right? So in the acute setting, the TIMI 22 trial or the Prove It trial showed that even in the acute setting, giving somebody an 80 of Lipitor reduces 14-day mortality by something like 20%. So it's really, really huge. Now, an ACE inhibitor also works. How do ACE inhibitors work in the case of an MI? They prevent cardiac remodeling. So if the heart has been hypoxic for a while, ACE inhibitor prevents the myocytes from becoming fibrocytes, so you won't scar and you won't end up with a low ejection fraction. They also make your heart have to work less. They vasodilate your arteries so that the heart doesn't have to pump as strong to get through the aorta and through the resistance in the arteries. So you got to try to, they also drop your blood pressure. So ACE inhibitors don't have to be started acutely. They can be started on day 2 or as their blood pressure tolerates it, before discharge. So ACE inhibitors before discharge. The last one is hemoglobin greater than 10. You want their hemoglobin to be reasonable. If a guy has an acute GI bleed and comes with a hemoglobin of 3, what do they die of? Anemia? No, they die from oxygen not getting to the rest of their organs. They may have liver failure, heart failure, brain failure. They go into things that need oxygen to live. If your hemoglobin is 3, your troponin is going to be high. You're going to be confused and short of breath and all that. No one dies from anemia. You die from what happens when your organs don't get blood. Now, nitroglycerin is optional. If they ask you on the test, which of these has not been shown to improve mortality or morbidity? Nitroglycerin. Nitroglycerin does, however, do what? Makes the patient feel better. It's a venodilator, all right? It dilates your veins, not your arteries. But it does have some coronary artery dilation, so they do feel the chest pain go away. You're treating yourself, you're treating the nurse, you're treating everyone else that says this guy still has chest pain. Now, persistent chest pain, I will tell you, you should go to the cath lab. If you've done all this, the guy still has chest pain, you're treating him like a STEMI. You're not waiting around. You're taking him right away. Non-STEMIs, supposed to go to the cath lab within the next 48 to 72 hours. The guy comes in Saturday morning, give him all this, stabilize him. On Monday, you can cath him. All right, figure out where the blockage is or where they all are, and then fix it. These ones are emergencies. This is probably the only true emergency in medicine. I don't know of any other thing where you got to come in immediately no matter what time of day or night it is. Now, morphine you should not give. It's a vaso and venodilator. That reduces perfusion pressure, all right? Your arteries and your veins drop their pressure, your mean atrial pressure drops. You're not perfusing heart tissue, let alone other tissue, but you're not perfusing the heart. In animal studies, infarct size has gotten bigger, but in human studies, one of the largest databases for ACS is the Crusade database or the Duke registry. All the hospitals in North Carolina and South Carolina are in the Duke registry. And they've shown a 1.48 or 48% higher mortality for people that got morphine. Now, they used to say, well, people that got morphine, they're less likely to complain of pain because it goes away. That's not actually the reason. It's because you're decreasing perfusion pressure, and, that's what happens. Now, over here is the SOB treatment. Let's say we get them through this acute MI, and they're going to be sent home. And you guys may see these people in your clinics. If you're family practice, internal medicine, even urology, whatever it may be. You got to put them on what I call the SOB treatment: statin, aspirin, ACE, beta. All the rest of the stuff is IV stuff and heparin, Lovenox. No one goes home on 2B3A inhibitors, IV, and all this. What you do end up on is these 4 drugs. These 4 drugs, this combination of 4 medications, gives you a 90% reduction in mortality. All right, so if you remember anything about coronary disease, please remember SOB. All right, they used to make cars, but I don't know if they do anymore. But statin, aspirin, ACE, and beta blocker reduce mortality by 90%. Okay, so remember that. Now, if they did get a stent, you got to make it SCAB. You got to add clopidogrel, SCAAB. So remember this, and you'll do really well. Now, how can they ask you questions on the test? I mean, they'll present a page with ST ovations and all this. What drug you want to make sure, what combination of drugs do you want them to be on when they're discharged, or do you want to take them, what's the next best step? In this case, open the artery somehow. If they don't give you the cath lab option, you could do thrombolytics. Here, you medically manage them. They'll have you pick some of these, but it'll be pretty obvious. They're not going to try to trick you. Now, on the complex, they will ask you 2-part questions. They'll present somebody coming in with chest pain. They'll say, what does this person have? And you should say, acute MI. And then there'll be another question, what should you give them first? And then it should probably be oxygen or aspirin, whichever one of those is on there. All right, so I remember the complex had they'll have one scenario and they ask multiple questions about it. So cardiac enzymes, you guys can you can review this. The one that goes up the first and fastest and leaves the quickest is myoglobin. Very non-specific for the heart. CK and CKMB, also not very specific, but they go up quickly and drop quickly. You're looking at like 4 to 6 hours, and they last 2 days total. Troponin, however, can last up to 2 weeks. Troponin, I think we talked about this last week, very, 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 very specific. It comes from the heart. Nothing else leaks troponin, okay? Somebody has end-stage renal disease, they're leaking troponin from their heart all the time, but they can't clear it. The reason they're leaking troponin is because of the volume shifts. They get dialyzed, their heart expands, and they get suck out volume, and they get ischemic. It's all from that. They have known coronary artery disease, and they're leaking troponin. Sepsis, heart failure, same thing. Somebody's septic, they're not perfusing many of their organs to begin with, so they're leaking troponin. They may not be able to clear it because their kidneys are also not getting flow and oxygen, so they're not going to clear it. So people may say, well, yes, sepsis and lung disease and kidney disease and all this leaks troponin. They don't. Troponin just comes from the heart. Other stuff makes it hang around longer, all right, or makes you not be able to get rid of it. But it comes only from the heart, so it's very, very specific. And we just said that. Okay. So we talked about ST elevations. It's always good to review. In the chest leads, the V leads, the shape matters. Any limb leads, it doesn't. The shape does not matter. Any new elevations is not okay. All right. Some people can have ST elevations that are pretty normal, up to 3 millimeters on this side and 1 on this side. But anytime if it's a new elevation or change, it's not good. We talked about the order of events. First, you get the hyperacute T's, ST elevations, T wave inversions, then Q waves. And Q waves kind of stick around. They may be there for 10, 20 years. So if somebody comes up with Q waves, we don't know when they had an MI, but they've had one. Well, what we do know is that it's at least been 2 hours. All right, they've tested how long does it take to develop a Q wave. It takes about 2 hours. So we know at least they've had, if they come to a chest pain, they already have Q waves, we know it's been going on for more than 2 hours. We can say that much. Reciprocal changes we talked about. Inferior reciprocates to AVL1, anterior reciprocates to inferior, lateral and anterior, we could say all reciprocate to inferior. We talked about this a little bit, maybe. If it's the RCA that's infarcting, and that's 80% of all infarcts, especially STEMIs, there you get hypotensive, bradycardic, because the RV infarct is from this side. Everything's kind of slowed down. Stuff on the left side, they're tachycardic, they're in more pain, the anterior wall is huge if it's the LAD, so they're in more pain, they're usually not doing so hot. But these ones probably die the most because of mismanagement of the RV infarct. So medications we kind of talked about, aspirin, Plavix, and you guys can read this on your own. It's not really hard to read. Beta blockers, Lovenox, heparin, 2B3A inhibitors, Lipitor, you can read about the studies and how much of an improvement it made. ACE inhibitors, 20% reduction in mortality, and even out to like 4 or 5 years, it had a huge reduction. So you guys can read this, they're making it available for you. Morphine, once again, contraindicated, and this is part of the Crusade trial that I printed out. Compared to patients not treated with morphine, patients treated with any morphine had a higher adjusted risk of death, odds ratio of 1.48 with a 95% confidence interval, and you can read the rest of it. But you will die, you'll be killing people if you give them morphine. Give them nitroglycerin instead if they're really in that much pain, or take them to CAT. They should be opened up. So we talked about the SOB treatment, 90% reduction. Now, the question of stress testing always comes up. All right, so there's three things you want to do in every stress test. Everyone gets an EKG. Everyone gets stressed. Okay, we're looking. What are we trying to do with a stress test? We're trying to give them a heart attack, basically, right? We're trying to make them ischemic. So there's lots of ways to do that. You can have them run on a treadmill for 10-15 minutes at an incline, and if they make it, they don't have coronary artery disease, similar to running a marathon. You can run. The Bruce protocol on the treadmill is really rough. It keeps going up and it gets faster and faster. They've designed the Bruce protocol so that even the most well-conditioned humans, well-conditioned athletes, will all quit between 10 and 15 minutes. The incline keeps getting higher and higher, and no one can really go much longer. I mean, maybe ultra-marathon people can, but it's designed so most people will become ischemic or get tired. So that's what we're trying to do. We're trying to see if we can induce any EKG changes. You'll see ST depressions everywhere. Remember, ST depressions do not localize. You'll see them mostly in V5. That seems to be the most sensitive. And then you'll see them the leads around V5, depending on kind of where they stuck them. But lead 2 and lead 3 as well. Now, we can make them run on a treadmill, which increases heart rate, makes them vasodilate, and we can check out their functional capacity. If they last 10, 15 minutes, that's really good. If they last 3 minutes, that's horrible. So that would be a really poor prognosis. Or we can do it medications. Adenosine is a vasodilator, so it gives you that vasodilation. The butamine increases your heart rate, which gives you the increase in heart rate. Nothing is as good as an exercise test because nothing else gives us functional capacity. So if we can run them, we'd rather run them. So how does adenosine work? It's a vasodilator. When you exercise, you vasodilate. So let's say this is your left main, or like your LAD. These are branches off your LAD. Normally, if your heart is at rest and you have a blockage on one side, oxygen will still, at least enough oxygen, enough blood flow will get to that side. We vasodilate you. This side is already maximally vasodilated because of the blockage. This side will vasodilate and blood will get sucked this way. So you get like a coronary steal syndrome. Less flow goes down this way and you get ischemic. All right, so exercise can do that and adenosine can do that. The butamine increases your heart rate where flow will go down the path of least resistance, and then you'll get ischemic on this distribution. So we have 2 ways of imaging these people, and you don't always have to image them. You can do just an exercise, but if you want to get really, really accurate or a little more sensitivity, and we can do an echo. We echo them before, look at how well their walls of their heart are moving, make them ischemic, and echo them right away afterwards. If one of the walls is no longer moving, or it's moving a lot less, then that area is ischemic. With nuclear, we inject them first at rest with a nuclear tracer, take pictures of their left ventricle and their heart. And then we stress them, with one of these modalities, and then check the nuclear again. Put the tracer back in, see if any part didn't get oxygen. The nuclear material, whether it's technetium or thallium, looks like oxygen to your heart. Your heart thinks it's oxygen, that's why it takes it up. So if any area is dim or not lighting up, then that area is ischemic. We call that a reversible defect. If it's reversible, we can fix it. We can open up that artery. If it's a fixed defect, then it's already scarred over. The person had an MI a long time ago, and that area won't light up before or after. That area will be dim before at rest and dim during stress, so it won't light up. So fixed defects we don't care about. But anytime you see the word reversible, then we care because we can fix it. So these are the different possibilities. You can do exercise only. If it's a young person, 20-year-old, kind of obese, wants to get back into a workout routine. All right, let's do a stress test. They'll monitor you, see if it's okay. They'll just throw the EKG on, let them run. Okay, you did well. Go ahead and start an exercise program. You can do an exercise nuclear, which is probably the most common. You can do exercise echo, which is good for young people as well. Young person, no risk factors. You don't want to find anything small. You just want to look at the overall big picture. You can make them run and check the echo. You can also do adenosine nuclear, inject them with a vasodilator, see if any areas dim out or don't get oxygen. Or you can do the butamine echo or nuclear. All right, and it would be similar. So stress testing now. So now you understand stress testing. Who is good to stress? Right. So you got to look at a patient's pre-test probability. Are you going to take an 80-year-old guy who's had 4 heart attacks and stress them, and then if it comes back negative, tell them you don't have coronary disease? They've already had 4 heart attacks. Is it even possible that they don't have coronary disease? No, they do. Are you going to take a 20-year-old, let's say an obese 20-year-old who hasn't worked out in 4 years, put him on a treadmill, and he doesn't last more than 2 minutes and quits? Are you going to tell that 20-year-old that you have coronary disease? Not really. So the 2 ends of the extreme you don't want to stress. Somebody who has known coronary disease and somebody who you think has a very, very low chance of having coronary disease. Now this is not how we really do it. You come to the hospital and say you have chest pain, you end up with a stress test. But this is how you should do it. So really, really low people, if you look at the low risk patients, if it comes back positive, the positive predictive value is only 21%. It's kind of a worthless test. So if we take one of you guys, throw you on a treadmill, you quit after 2 minutes, let's say your EKG looks a little funny. Okay, you have a positive stress test, we're going to cath them, The whole point is to avoid capping people, right? I mean, we're trying to do something non-invasive. So we're not going to cap a 20-year-old, because the positive predictive value is very, very low. You take somebody who's really high risk, you put them on a treadmill. The positive predictive value is 83%, but we kind of already knew that. The guy who's a high-risk patient who has a pre-test probability, they already have coronary disease, or we already know they kind of do because we capped them a few years ago and they had like a 70% region or 60%. The positive predictive value is not really helping us that much because we already know they have it. If it's negative, I'm sorry, we're a high-risk patient. Positive predictive value is 90%, but we already knew that. Right? We already know they have coronary disease. So it's really kind of a waste of time to do it. If the test is positive, it's 98%. But we already know with almost 100% certainty that this guy has coronary disease. They've had a few MIs, they've had a few things, so we already know that they have that. Now, if it's negative, you drop to 83%. So if a guy who's had 3 heart attacks passes a stress test, they still have coronary disease. 83% likely that they still have coronary disease. So it's kind of a worthless test. Now, it's the intermediate people that we want to check. These people, they're starting out at a risk, where are we? Starting out, the intermediate people at risk of 25 to 75%. This is like your 40-year-old, hypertensive, obese, smoked a little. We don't know they have coronary disease, but they're not low risk either. So we do want to stress these people. Let's say they're 50%. The average between 25 and 75 is 50. Their pre-test probability of having coronary disease is like 50%. If it comes back positive, it goes up to 83%. If it comes back negative, it drops to 36%. So this is a good test. You want to check these people who they're in the middle range. You're not really sure. They could have it. They might not. They have a few risk factors. They've done a few dumb things. We could check it on those people. We talked about RV infarcts or not last time. I can't remember. We did. So if you knock out the RCA, the RV branch comes off the RCA. All right. They will be hypotensive, they have JVD, they'll have clear lungs because your RV is not functioning. The part of the job of RV is to suck blood back to your heart, and you pull in your legs and your veins and your neck. And part of it is to pump blood into your lungs, and it won't do that. So you have clear lungs. The treatment is, first of all, take off the nitro, because I'm sure somebody already gave it to them. They think somebody's having a heart attack, you give them all nitro. The next point is give them all fluids. You got to fill them up so that the left ventricle is pumping it all the way back to itself. You don't want to do any of these things. You should be doing morphine anyways, but you never want to do anything to drop their blood pressure more than it already is. Now, the best way to know if somebody has a RV infarct is the ST elevation in 3 over here is higher than the ST elevation in 2, and that's it. It's pretty easy. You don't need a right side EKG. You don't need any fancy tests. All you need is this. This is very, very sensitive, and this is why. Lead 1, lead 3, lead 2. Here's your RV. So we talked about AV blocks last time, so we'll kind of skip this. But remember, it's all about the PR interval. The PR interval here is over 200. PR interval here makes no sense. You compare one to the other, they're all different. Here you have group beating, PR prolongs then drop, PR constant then drop. These guys need a pacer, these guys don't. And they may ask you something, they may show you a rhythm and say, what does this patient ultimately need, or what's the next best step in management. You want to put on the temporary pacer first, the pacer pads, but then they'll ultimately need a pacer. We talked about the arrhythmias. Most important thing is figuring out, is it wide or narrow? Wide rhythms come from the ventricles, narrow rhythms come from on top. We call those supraventricular. Now the word SVT, people throw it around, and they usually say, if they think somebody has AVNRT, they say, oh, he's an SVT. But this is actually just one SVT. These are all SVTs. Right? The other possibility is that they have a regular one of these rhythms, but they have a left or right bundle branch block, and that's why it looks wide. Okay? So whenever it's wide, figure out is it VTAC or VFib. VFib is pretty easy to figure out. Or is it like AFib with a left bundle, or just sinus tach with a left bundle, or a sinus rhythm with a left bundle. And we talked about ventricles, stuff comes from down here, the supraventricular stuff comes from up here. It always has to hit the AV node to cause a narrow contraction. If it hits the AV node and the conduction is normal, that's what gives you a narrow QRS. All right, it hits the AV node, goes down the bundle, hits both ventricles at the same time, they both contract together, that's why you end up with a narrow QRS. If they have a left or right bundle branch block, that's when it gets wide. One side's contracting first, slurring into the second side. So atrial fibrillation is the most common rhythm. Almost everyone ends up with it. If you live long enough, you'll probably get it. No, but about 5% of the population has it. The debate is always, what should we do about it? This is the irregular rhythm, no P waves. The atria are not contracting. The atria just kind of staying still. They fibrillate, and maybe occasionally there'll be a P wave of atrial contraction, but not really. You want to look at something called the CHAD score. And I'm sure they beat this into your brains during rotations. But the CHADS 2 score, C is for what? CHF, hypertension, age over 65, diabetes, and stroke, you get 2 points. So if they have 0 to 1, you can just put them on aspirin. If they have 2 or more, you can put them on Coumadin. Now there's a new one called CHADS vascular. If they have vascular disease, or they're female, or their age is even lower, 65, because in this one it's 75 actually, but if they're 65 and a female and they already have vascular disease, they're higher risk, so that you want to put them on Coumadin. So that's something new. I highly doubt we're going to test. But you got to get their rate down, so you got to put them on a beta blocker. And if they shouldn't be on a beta blocker for whatever contraindication, you know, they have, they're always wheezing, they're always an asthmatic, or whatever it may be, you can put them on a calcium channel blocker. Now there's 2 kinds of calcium channel blockers. There's the dihydropyridones, like amlodipine, like cardipine, nifedipine. There's a lot of pines, but they end with pine, all right? Or there's the non-dihydropyridones. There's diltiazem and verapamil, all right? These ones kind of act like beta blockers. They just slow your AV conduction. They do weaken your heart's contraction a little, but they act more like beta blockers. So you can put them on verapamil or diltiazem if their lungs are really, really bad. So ACLS, I don't know if we talked about this, but you guys are going to be running codes pretty soon, and they may ask you something on the test. So there's only really 2 scenarios. You have VFib, VTAC, or asystole. Now asystole is easy. You guys see on TV, somebody's asystole, the monitor's flat, they shock them, right? No, that would be a very bad idea. There's no point in shocking asystole. You got to give them drugs. First of all, you got to give them chest compressions, because their heart's not pumping, their heart's not doing anything. Or if they have PDA, their heart thinks it looks like it's pumping on the monitor, but they have no pulse and they're not really pumping. So you got to pump for them. So you got to do chest compressions. Never stop chest compressions at either point. You come in, code blue, you feel the patient, no pulse, start chest compressions. There's no, the rest can wait. People live longer if you start pumping their heart for them. Epi and vasopressin are the standard of care. You give them epi and vasopressin. They actually have taken atropine out, so just delete this one. Atropine is no longer in ACLS protocols. Epinephrine does the same exact thing, and you keep giving them epi as long as you want, and you can actually put them on epi drip afterwards. So this one is easy: chest compressions and some epinephrine. All right. VFib and VTAC. Now, if a guy has VTAC and he's talking to you, he's like, you know, I just kind of feel funny. I don't know, my heart, I feel like it's racing or something. If they're talking to you, you don't start chest compressions. You don't start shocking them. You don't. I mean, that would be that's like torture. That would be a very, very bizarre morning for that person. So now, let's say they lose their pulses. They start getting kind of unconscious and, they're not even talking anymore. Fine. Then you can start chest compression. Somebody's getting a crash cart, put the stickers on them, and then you defibrillate them. All right, that's the treatment for VFib and pulseless VTAC. Okay, and then amiodarone, magnesium. Amiodarone and magnesium are very, very good at suppressing ventricular arrhythmias. All right, and if somebody's pulseless, amiodarone. If they're in VTAC, VTAC is pulseless. Amiodarone is first line. Give them 300 amiodarone, and then you can worry about the rest later. And magnesium also helps. Now, if that doesn't work, or let's say they're allergic to amiodarone, or they got like an iodine allergy. First of all, no one really has an iodine allergy. You will die without iodine. What they were allergic to is the stuff that the contrast was mixed with. All right, we don't use those kind of ionic, ionic contrasts anymore. But no one's really allergic to iodine. So you could probably give them amiodarone without a problem. But let's say they're allergic to actual amiodarone. They went in anaphylactic shock last time. Worse shock than this. You can give them lidocaine, and then if that isn't working, you can use procainamide. So you guys will be running codes. Just remember this: asystole, PEA, chest compressions and epi, VFib, VTAC, chest compressions, shock, and amiodarone. That's it. So now we'll get into some stuff that's more cardiological, hypertension. So you guys know all the drugs, and you've seen hypertension, it's very, very common. Normal is 115/75. Every 20/10 higher than normal, your risk of stroke doubles. All right? So if a guy's 135/85, they have a 2 times higher chance of stroke than anyone else. Now, if they're 155, that's obviously 4 times. So for every 20/10, it's higher. You have to identify the risk factors. Now, in young people, say a 20-year-old or a 30-year-old comes in saying, I have hypertension, and I don't know why, and it's hard to control. It's not just every 20-year-old that comes in having hypertension. Let's say you put them on a hydrochlorothiazide or something, their blood pressure's still like 170 or something crazy. You want to look for secondary causes, and they're pretty common. But I will warn you, obstructive sleep apnea is the most common cause for hard-to-control hypertension. So medical books need to be rewritten, because they will always talk about renal artery stenosis, carcinoid, pheochromocytoma, fibromuscular, whatever, all these things. But I can tell you, almost 90% of these hard-to-control hypertensive have sleep apnea. All right, you can ask them screening questions. Do you ever wake up at night, can't breathe? Are you always tired during the day? Do you snore? You can ask them everything, and you don't have to be obese to have sleep apnea. You could just have like a malformed or slightly differently formed pharynx or whatever. But usually they're obese, so make sure it's not that, because that's the most common, it's the easiest to fix. Renal artery stenosis can do it, carcinoid. If it's a young woman, 30, 40 years old, hard to control hypertension, she may have fibromuscular dysplasia. This is like a thickening. It basically gives you renal artery stenosis bilaterally. It's a thickening of the intima of the arteries going to the kidneys. Atherosclerosis, it gives you renal artery stenosis as well, but it's an older guy. It's the same atherosclerotic process that happens in your aorta, peripherals, coronaries. They just get plaques, and eventually it's bad enough, so it's giving them, really hard to control hypertension. Pheo, pretty rare, and hyperaldosteronism, also rare. If they have low potassium and hard to control hypertension, you want to look for this. So hypertension, you have different kinds of drugs. Vasodilators, you got these guys. I will tell you that ACE inhibitors are vasodilators. People don't realize that they don't just block ACE. They are actually also vasodilators. Thiazides, especially dipamide, is also a vasodilator. Someone will take a hydrochlorothiazide or a dipamide, you lose, it's a diuretic. But after you've been on for 3-4 days, you actually get a vasodilatory effect. So you don't always see, if you start them on a low dose and their blood pressure doesn't drop right away, wait about a week until it's finally giving them the maximum vasodilatory effect. Rate-controlled drugs, you've got your beta blockers, calcium channel blockers, your renin-aldosterone angiotensin system, you have aldactone and ACEs, diuretics, all these diuretics pretty easily. Now the question is always going to be, what do you put what patients on? All right, we know how to control hypertension, but certain patients should get certain drugs, right? So diabetics should get ACEs and ARBs. Prevents microproteinuria, and it protects their kidneys, yada yada. Heart failure, they should be on diuretics, beta blockers, ACEs, and aldosterone antagonists. And we'll get into that later on during heart failure. Post-MI, they should be on a beta and an ACE. We talked about that, part of the SOB treatment. Chronic kidney disease should be on an ACE. Now, if they have chronic kidney disease and their creatinine is always like 1.5 or 2.1, does that mean you stop the ACE inhibitor? I mean, that's like stopping aspirin in somebody with coronary disease. It's a bad idea. It is actually protecting their kidneys. Their kidneys are just not so hot. They're deteriorating over time. So you don't always want to stop it. Now, if you start them on an ACE and their kidneys suddenly skyrocket or double their creatinine, that's a different problem. They have some kind of renal artery stenosis or something. But most patients that are pretty stable, they need to be on it. If they've had a stroke, thiazide diuretics and ACEs help. So now we'll talk about diabetes. We call it cardiometabolic syndrome, insulin resistance, metabolic syndrome, whatever you want to call it. Diabetes now is an equivalent to coronary artery disease. We've already kind of talked about that. So you either have type 1 or type 2 diabetes. Some people still call it insulin-dependent diabetes or non-insulin-dependent diabetes. If you've graduated medical school within the last 10, 20 years, you should not be calling it this, because type 2 diabetics end up on insulin, all right? So it's either type 1 or type 2. It's not non-insulin dependent or insulin dependent, but some people still use that. But it's either type 1 or type 2. So This is diabetes in general. 92% of the population do not have diabetes, although these numbers may be revised soon. Fasting sugar should be under 100. 92% of the population, their fasting sugar is under 100. 1 hour after a meal, your blood sugar should never be over 140. And OB-GYNs like checking this one. And your hemoglobin A1C is under 6. If we took most of you, 92% of you, and checked these values on you, this is what they'll be. This is what non-diabetics have. This is what your values look like. So type 2 diabetes is insulin resistance, the most common kind of diabetes. Only like, if 92% of the population doesn't have diabetes, of the people that have it, 92% have type 2. Only a small fraction has type 1. We don't know how you get type 1. It's an immune reaction. Your body destroys your beta cells. You cannot make insulin anymore. There's no genetic correlation. No one really knows how you get it. Maybe you got a virus or something wrapped up your immune system, but you destroyed your own pancreas, basically. So no one knows how you get it. Type 2 diabetic is insulin resistance. You make tons and tons of insulin. It's just that your body is not capable of using it. So it's genetic. You were born with it. They've been able to demonstrate in newborns that they have insulin resistance when you get really, really high glycemic loads. So it's not something that you gave yourself. And doctors, something that really bothers me is they try to blame the patients for their diabetes. Well, you ate too many jelly donuts in your life. It's not their fault. They were born with this. Sure, eating jelly donuts isn't helping. But if we took a non-diabetic, if I ate 300 jelly donuts a day for the rest of my life, and I became 1,200 pounds, I would not be diabetic. There's nothing you can do to give yourself diabetes. Now you can make it worse, or you could argue maybe everyone has some baseline insulin resistance and you can exacerbate it. But if you don't have the genetics for it, you could eat whatever you want and never be diabetic. 80% of our country is overweight. 35% or 40% are obese. Only 8% have diabetes. All right, it has nothing to do with how much you eat or how fat you are or anything. So teach patients not to blame themselves for having diabetes. They all say, yeah, when I was a kid, I ate too much. No, there's nothing you can do about it. You could help it by not eating much, but it's not going to go away. So as we get older, heavier, more inactive, eat more, or take steroids, or you have a stressful situation, or you're pregnant, which is a stressful situation, or if you're on hormones like birth control pills, all of that will bring about your insulin resistance. We used to diagnose diabetes at age 51. Type 2 diabetes normally used to be diagnosed at age 51. Now it's 41. People are older, heavier, more inactive, more steroids, more stress, whatever you want to say, but that's making us diagnose diabetes earlier. So all these things help or hurt your insulin resistance, but they didn't give it to you. Okay, and I really want to stress that there's nothing you can do to give yourself diabetes. Your pancreas, for the longest time, keeps making more and more insulin, all right, and it overcomes the insulin resistance. Eventually gets tired and it quits, and then we finally diagnose diabetes. Now, I will tell you, we could probably solve this problem earlier if we didn't wait so long to tell people that they have diabetes. The solution to this is diet, exercise, weight loss, and metformin. All right, this should be the baseline treatment. The American Diabetes Association, the World Health Organization, they all say when you initiate lifestyle modifications, you have to start metformin too. You don't give them 3 months. This is a problem they've had for years. They were born with it. You don't give them 3 months or 6 months, hey, let's see what you can do. They can't do. What are you going to do? Unless you get a genetic transplant or something, it's not going to work. So you need metformin. Now the problem is, we wait till their blood sugar fasting is what? Over 126, right? For the longest time, and I don't know what number they taught you in medical school, but for the longest time we used to tell them a random sugar over 200 or a fasting over 125, so like 126 or higher, you're diabetic. The problem is, normal is under 100. So if they're 110, are they not diabetic? Wait a few years, they're 113, 120, 124. Let's say they go on for another 5 years at 124. Are they not diabetic? This is not like an either or. It's a spectrum. As you get fatter, older, heavier, more inactive, it becomes more and more obvious. So we don't need to wait till people are like blatantly diabetic and start having all the complications of it to start treating them. In our clinic, in my cardiology clinic, anybody who's over 100, we send them to the endocrinologist. Say, look, you have insulin resistance. and you are basically a type 2 diabetic, here's an endocrinologist, you can go see them, and if they don't, and if they're, or we tell their primary care doctor, start them on metformin. If they come back next time they're not on metformin, we'll start it. So that's what we got to do. You can't keep playing games with this. You lose your legs, you lose your eyes, you lose your kidneys, you lose your heart, you get a stroke. This is not a fun disease. This is by far the worst possible disease you can have. No other disease affects every single artery and every single organ. All right, you have high sugars, you're chronically inflaming your arteries and destroying your organs from the inside out. If I had to pick a disease, there are plenty of cancers I would rather have than having diabetes. This is by far the worst possible disease humanity has ever seen. And you guys see it all the time with people getting amputations and heart attacks and strokes, and they're like 40 years old and they look like they're 100 and they barely have any body parts left. So I like to stress diabetes because it's a huge problem. Now, metformin is the best drug we have for diabetes. Of course, they may need more later, but the sooner we put them on this, the better. In the diabetes prevention trial, it was demonstrated, about in the 1970s, they did this trial where they put people on prednisone, secretagogues, metformin, diet, exercise. The people that ended up on diet, exercise, and metformin had the best results. And even if they took metformin just for a few years and stopped, 20 years later, they still had less insulin resistance than their counterparts. So if they did diet, exercise, and metformin, any one of those three, or all three together, we saw benefits even 20 to 30 years later. So there's some kind of memory effect where if you're taking metformin or you exercise or did some dieting, you become less insulin resistant, and even 20 years later, we still see that you're doing better than the people that got all the other stuff. So I will stress that metformin is the #1 choice, and the American Diabetes Association says the same thing. Start people on all of them, diet, exercise, and metformin, and don't wait so long to tell people they're diabetic. In fact, you could argue that a fasting sugar of over 90 is diabetic. No one should have fasting sugar that high. We took one of our ICU students once that he didn't believe us. We made him eat Chinese food with like sweet and sour, that sugary sauce and pancakes with syrup. And we waited an hour and we checked his blood sugar. It was 71. So no one, and the cutoff was 140. After an hour after eating, it should be less than 140. He was 71, just to give you an idea of how normal people react to huge, huge carb loads. Now, metformin does not cause lactic acidosis. The boards love this question though. Everybody you talk to thinks metformin causes lactic acidosis. In all the literature and all the research that they've done, there hasn't been a single causal case where the person got lactic acidosis cause of diabetes. So don't fall for that. There was a prior drug called phenylformin. Phenylformin was discontinued and taken off the market because it did cause lactic acidosis and killed people. They wouldn't let metformin come to market unless they put that in their product insert. So that's why it's in the PI, and they got on board somehow. The most common problem with metformin is if somebody gets a contrast study while on metformin, you get a contrast nephropathy. It's the cheapest and best drug for type 2 diabetes. It does a lot of things. First of all, it sensitizes you to insulin. Second of all, you lose about 10 pounds. Third of all, it blocks carbohydrate absorption in your GI system. Thirdly, it prevents your liver from making more sugar. Glycogenesis gets blocked. So you try to titrate it over 4 years. Don't start somebody on 2 grams a day. All of a sudden, they'll get diarrhea and they're not going to like it. So you start them on 500 once a day, wait a week, 500 twice a day for a week, 1 in the morning, 2 at night, and then 2 and 2. Just take your time. If they start getting GI, cut back. But you got to try to get them to the dose. So this is how your body normally secretes insulin. This is going to be on board, you know. So you got to know. So when this is your basal level of insulin. When you eat, your pancreas gives you boluses. They used to give this 70-30 mix of insulin. This is old. You don't have a baseline insulin at all. You don't have a basal. This is your basal. You don't have any basal. You get these whopping boluses that die down, and you have no insulin in these gaps. So that's very bad. This is really old. If any of your doctors are doing this, you shouldn't be doing it. Now we have Lantus, which is insulin glargine, and the word glargine wasn't on my comment, so I didn't know what the hell it was. But insulin glargine or Lenti and Lessapro. This is Novolog and Humalog. All right, these are shorter acting. This is much more physiological. This is what people should be doing. Okay, so the new American Diabetes Association guidelines, this was back in January 2010. Now, anybody with a hemoglobin 6.5 or higher can be told you are diabetic. So that is very good. The World Health Organization, the ADA, got together and decided it's going to be 6.5. I was hoping for 6 or something lower, but they picked 6.5. So if you're treating a diabetic, though, you want to get them under 6. If somebody is diabetic, you hope for their A1C to get under 6. Now, if it's a really old person and they're having too much hypoglycemia and they're not really well, compliant, then fine. Let them be around 6 or 7 or whatever. Start metformin right away, add a basal insulin. You can add glimepiride, which is a 3rd generation. It's very specific to the beta cells in your pancreas, not glyburide or some of the older ones. It should be glimepiride. And then you can use some of the new agents. And these are probably not going to be on your test, but Januvia, Byetta, some of the GLP inhibitors or incretin agents. Weight loss is huge. I always tell people, you could get to your ideal body weight. You can get to within 10% of your ideal body weight just by diet alone. The problem with doctors is we tell patients diet and exercise. Yeah, exercise is good for you, but you don't need to exercise to lose weight. The fact that we tie them together, who has time to exercise? Patients come in thinking, well, I don't have time to exercise, so I'm not going to be able to lose weight. That's not true. You do not even have to move a muscle. If you stop eating, you will lose weight. And you can get to 85 or like 90% of your goal weight without moving a muscle. You just have to stop eating. So don't tie those two together. If you go into primary care or cardiology or something, or your diabetes, whatever, you're counseling patients, do not make them think that diet and exercise have to go together for weight loss. Yes, exercise is great, it's good for your heart, but you don't burn that many calories running on a treadmill. If you stop eating, you will burn a ton of calories. All right? I think I have an example of that. Okay, so a 200-pound person, if they jog for 3 miles, how many calories will they burn? 300 calories. 1 plain bagel from Panera. 3 miles on a treadmill. Okay? A 200-pound person doing squats for 2 minutes straight, and squats is easy, you don't have to have any weight on it, you just go up and down. For 2 minutes straight, which I doubt anyone will be able to do, but if you don't stop, in 2 minutes straight, you burn 320 calories. Alright, so you can eat that bagel if you really want to. But I highly recommend resistance training. We always tell our patients in cardiology, don't just run on a treadmill, you're kind of wasting time. It takes an hour to run 3 miles, just do squats for 2 minutes. You'll burn that same amount of calories. And also separate diet and exercise. Yes, running on a treadmill is good for your heart, you probably won't have heart disease, blah, blah, blah. But if you want to lose weight, you have to stop eating. It's not tied to exercise. All right, exercise is good for you, but don't combine the two, because no one ever, you get these 50, 60-year-old guys, they never have time to exercise, so they think they can never lose weight. That's not true. You can lose plenty of weight. If you stop eating, you're going to lose a lot of weight. So we'll skip this one. So dyslipidemia, this is the other cardiology thing. You guys all know the guidelines, all right? These are going to change soon, all right? The total cholesterol, your LDL, your HDL, triglycerides, all these things are going to change. There's the new ATP4 guidelines coming out. So you guys can read this slide on your own. But if they do ask you, if they ask you a question on the board, it's going to be something like this. A guy comes in, whatever they describe, like a 56-year-old guy, he has a cholesterol of 240, what do you want to do? What's the answer? Diet and exercise first. This one you can give them time. Try changing your lifestyle, try changing your exercise, whatever. Now I will tell you, what's the number one thing that we should tell them not to eat? Anyone? Saturated fat. You guys know what saturated fats are? They're fats that are solid at room temperature. Butter, chicken skin, steak fat, the fat on steak, that's what increases your cholesterol. Eating cholesterol does not increase your cholesterol, all right? Eating cholesterol may actually improve your HDL and may cause your liver to not make as much cholesterol. So eating cholesterol is not the problem. All right? Your liver makes all your cholesterol. This side, right? Your liver makes 85, 90% of your cholesterol. The signal for that is saturated fat. When you eat a stick of butter or the fat on the steak, there's really nice juicy steak or lamb chops or pork chops, All that stuff is saturated fat. That's what tells your liver, hey, we need to start making cholesterol. We got to get rid of this stuff somehow. We'll just store it in your arteries. Right? So that's what you don't want to happen. Okay? So you tell patients, don't eat solid fats. And that includes cheese. Now milk is kind of tricky because it looks like liquid, but it's little fat particles floating in liquid. So dairy products, milk is liquid, but it is a bunch of saturated fats suspended in a liquid milk. Whole milk is 4%. I don't know if you guys know this. 2% milk is half, and 1% is half of that, and skim is almost nothing. So normal milk is 4% fat. So that's a lot of saturated fat, but this is your basic guidelines. So once again, cigarette smoking is the #1 problem. And I don't know why people would smoke, but when you're counseling young people to quit smoking, you don't want to tell them, yeah, you may get cancer when you're 60 or 70, you'll probably die, or you'll be on an oxygen tank for the rest of your life. Yeah, that may happen, but young people don't think about something 20, 30 years from now. They're like, yeah, well, we're all going to die anyways, right? You got to tell them about the short-term consequences. They get wrinkles, their teeth look yellow, their hands smell, their hair gets all crinkly, your skin looks awful, all these, like, you smell like you smell real bad. It's a horrible thing in the short term. No one wants to date you, it's just disgusting, blah, blah, blah. Sell young people, especially teenagers. All categories and all age groups have stopped. The incidence of smoking has gone down, except recently, in the last 10 years, there's been a slight blip in teenagers. People like 22 and younger have been starting to smoke a little bit more than before. So you got to counsel them on stuff that matters to them. Dating, Facebook, Twitter. So there are lots of agents. The guy comes in with high cholesterol, and you tell him this, he's been doing diet and exercise on the test. He's been doing diet and exercise for 6 months. He's cut out all saturated fat. He just eats like celery all day. His cholesterol is still 220. Now what do you want to do? You should start him on a statin, right? That is the gold standard, all right? There's nothing else works as well as statins. Get them to as high as you possibly can. The strongest statin is what? Rosuvastatin, Crestor, the strongest statin. At 40 milligrams, causes something like a 60% drop, or maybe even more than that in some people. But it has the strongest anti-LDL and cholesterol effects out of all of them. Let's say they're on Crestor 40. Now you can play around with Zetia and phenofibrates and all this other stuff. But statin is the #1 choice. So, and don't mess this up. Well, yeah, let's put them on Zetia. The farm rep came in today giving me a ton of Zetia or Vytorin, Lipid and Zetia together. They take one pill instead of two. That stuff costs a lot of money. Why don't I just put them on like simvastatin, which is already generic, and some of these other ones are going to be soon. Now, simvastatin, recently the FDA, like a couple weeks ago, changed it. You cannot start somebody on simvastatin 80 anymore. The chance of myopathy is much higher. Out of all these statins, the one that gives you the most myopathy seems to be simvastatin, and it is dose related. They've already been on it for 12 months or more, and it's not a problem. Keep them on it, but don't start any new person on a higher dose of simvastatin. So you got to get your goals correctly. Anybody who's on a statin and has risk factors of coronary disease, diabetes, whatever, you got to try to get them down to an LDL under 70. And I will tell you, cardiologists suck at this. They've looked at patients who see a cardiologist. They've seen how many of them are at goal. Less than 5% of patients who actually see a cardiologist, let alone the other doctors, are at goal for their fasting lipid profiles. That's horrible, all right? If they start doing pay for performance, none of us are going to get paid, all right? So this is really, really bad. Your total cholesterol should be 120 to 140, all right? Don't mess around with this. We get patients all the time that come in and say, my doctor sent me to you. They're on like Lipitor 10 or whatever Lipitor they're on. And their total cholesterol is 198. So if you're going to put somebody on a statin, you might as well get them to a reasonable number, right? If somebody's on a statin and their cholesterol is still at 189, why would you want that? Would you want your cholesterol to be 199.9? Yeah, that's under 200, right? The number is 200 now, for now. Would you want to be that guy that's at 199.9 and your triglycerides are through the roof and all that, and your doctor tells you, oh, you're fine, you're borderline, now you're under the borderline. That's not good, all right? If you're going to put somebody on a statin anyways, and they're going to be taking that one pill every night, might as well put them on a dose that's going to get them something reasonable. We always try to get them around 120 to 140. No guideline says this now, but we want their total cholesterol somewhere in the low hundreds. The new guidelines will come out, and I don't know what the number for the total cholesterol is going to be. I'm hoping it's under 160, but we'll see. Anybody with diabetes or already had an MI and all this other stuff, they should be a lot lower. It should be 70 or less. Do not mess around with this. So metabolic syndrome, there's a definition of it, and you guys all know it. What is metabolic syndrome? They have the lowest HDLs, they're the fattest people, they have the fasting glucose that's over 110, they have high blood pressures, whatever it is, all right? So you all know the definition. All we're doing in metabolic syndrome is selecting out the worst diabetics, all right? We're taking the worst diabetics with the lowest HDLs, the highest LDL, the highest inflammatory markers, the most adipose tissue, the highest blood pressures, and saying, oh, by the way, did you know that people with metabolic syndrome have a higher incidence of cardiovascular disease? Well, that should make sense, right? You're taking the worst of the worst. I mean, you're like skimming off the top. You're taking the worst of the worst and saying, hey, you have a high risk. Well, that's obvious. So they have insulin resistance. We may not call them diabetic yet, because metabolic syndrome it's 109 in Europe and 110 here, but that's the cutoff. But remember, it's not the 126. So they're not looking at full-blown diabetics. These are the ones that doctors like to call borderline. Well, you're not really borderline. Remember, you're born with it. It's not borderline anything, you have it. So we're taking the worst of the worst diabetics with all these bad states of everything, and we're telling them, you guys are going to do poorly in the cardiovascular world. You're more likely to have an MI, more likely to have a stroke, you're more likely to have peripheral artery disease, etc. So that's why metabolic syndrome is bad. So syncope is another cardiological topic. What is syncope? Brief loss of consciousness, right? So, what causes syncope? Blood is not getting to your brain, okay? The only way that can happen is if something happened to your heart, right? If your heart isn't pumping, or it's in a fast rhythm where your cardiac output is too low, something happened in your heart, like aortic stenosis or something real bad, you're no longer perfusing your brain, you fall down, and then you recover. It's brief. Because if it didn't say brief, loss of consciousness, you could also be dead and you look like you've lost consciousness. But it's brief. The signs and symptoms are, I started getting lightheaded, I started getting weak, blurred vision, blah, 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 and then I fell down, found myself on the ground with a bunch of people looking at me. So that's usually their story. Now, nothing neurological causes this. So if you get a Syncope patient in the hospital, they always order MRI of the brain and carotid Dopplers, and they try to work out something neurological. Your brain cannot give you a sudden, brief loss of consciousness. Has your brain ever done that? Maybe if you're sleeping, but your brain cannot suddenly, you're walking around and boom, you drop and your brain, something happened to your brain. Now, a seizure is the closest neurological thing that can mimic this. All right, somebody has a seizure, and no one is there to see, you find yourself on the ground, you woke up, something's not going right. You may think you had syncope, and you may have had syncope. Now, you may lose bladder control during a seizure, but that's not always necessary, so we don't know. A hypoperfusion of your brain can give you a seizure. If you have an area of your brain that's very dependent or hyperactive or whatever, if you don't get oxygen there, you may have a seizure. So that may be one thing that gives it to you. But I will tell you, 99% of the time, or 99.99% of the time, something happens to your heart. All right, so there's three main kinds of syncope. Okay, neurocardiogenic, or vasodepressor syncope, or vasovagal syncope. These are all things that cause it: pain, stress, performance anxiety. I passed out before I started talking today. Coughing, swallowing, carotid sensitivity, all of these things. So what happens here is your vagus nerve is hyperactive, or you overstimulated it, your heart rate drops, your blood pressure drops, and boom, you pass out. Last a few minutes, you wake up. Right? Cardiac problems that can cause this are arrhythmias. Somebody goes into VTAC. Your heart's beating too fast to fill up, you fall. You're not getting enough forward flow. You could have a PE. If you have massive enough PE, you get hypoxic, eventually pass out. You can have aortic stenosis. If you have not enough flow going forward, let's say you get out and exert yourself a little, suddenly supply and demand don't match anymore, you pass out. The other option is orthostatic. You could be dehydrated. This is the guy who drank alcohol, was staying out all night, you know, at the baseball game, drinking, didn't drink any water, got up from his seat too fast, and boom, fell. Somebody found him, his buddies picked him up, brought him in. That's called orthostatic hypertension. All right. Autonomic insufficiency is another problem. These are diabetics usually. When you stand up, blood pools in your veins, right? Your autonomic system contracts, and your blood goes back to your brain. These people have an insufficiency of their autonomic system. When they stand up, that reaction is really, really delayed, so they fall. People who are anemic, your hemoglobin is 5. If you get up to do something, you may feel lightheaded and pass out. So syncope falls into one of these three problems. Now, it's always cardiac. If you get a history, if you talk to the patient, you can find out exactly what they have. History is syncope is a diagnosis by history. You can talk to them, you know exactly what they have. 99% of the time, or I say like 90% of the time, it's this. 90% of the time in the ER, guy comes in, says he passed out, he was going to pee or swallowed something big or whatever. You can tap him on the shoulder and say, see you later, have a good day. You just cured him. You'll never have this again. 85, 90% of the time, that's what they have. You can tap them on the shoulder and say, see you later. All right? Now, if they're older and they have coronary disease and some other things, yeah, they may have one of these. Or if they have orthostatic hypotension, I was out all day, drinking, out in the sun, you know, no AC. These are little old ladies. Well, they're on air condition. The room got really hot and they eventually passed out. Well, give them some fluids, send them home. They'll be fine. It's these guys that you worry about. So the first step is get an EKG. If it looks rock solid, you're pretty much done. An EKG and an echo, sorry. If you get an EKG and an echo and it looks rock solid, there's nothing to do. Now, if their EKG doesn't look exactly right, they got some Q waves or some, you know, a little bit of ischemia going on, then you should stress them. Because if they have a focal area that's not getting oxygen, they may be going into arrhythmias, they may be having other problems. So usually your workup should be EKG and an echo. They may ask you this, what's the first thing you want to do? EKG. If they ask you, there's no gold standard really, history. But if they ask you what else you want to do, after you already got an EKG and it looks fine, what else do you want to do? You should be getting an echo. You don't need carotid Dopplers, you don't need MRIs of the brain, you don't need anything. So this is just kind of another summary. It's not neurological. So this is what you need. You need to know that they're not anemic. You need to know they don't have electrolyte problems. EKG, echo. If they have risk factors or whatever, you can get a stress. If it keeps happening and you still can't find the cause, and a lot of times, something like 35% of the time, you'll never find a cause. But you can put a Holter monitor, loop monitor, and see if they're having any rhythms that we're just not catching. Do not get carotid Dopplers. Okay? If I include both of your carotids, what happens? I'm doing it right now. What happens? Am I passing out? Can I do this all day? Probably. You still have flow from your vertebrals. Okay, so let's say this, you do a carotid Doppler and this comes back 100% occluded. And this one is 70% occluded or 80%, whatever number you want to pick. Is that why they're passing out? No. You still have flow through your vertebrals. Carotids, if we include both your carotids, I mean, you could probably eventually pass out. But even if we include them right now, I can almost guarantee I can continue doing this entire talk without ever getting lightheaded or passing out in a normal person. All right? So there's no point really in doing this. Now, if they had a stroke, fine. This is a very good test. If they had a stroke, they have right-sided weakness or whatever, please check this. 34% of the time, we never find an answer, we never find a cause. You can get orthostatic blood pressures if the person's telling you, I stood up and I get lightheaded. You got to check it 3 minutes after they stand. They got to lay down for 5 minutes, check their blood pressure, stand them up for 3 minutes, then check their blood pressure and heart rate. People kind of screw that up. Now, this is gap acidosis, and I'm sure you had a talk on this case, but this is the only 6 that they're going to ask you on step 2 or step 3. And I've taken this test recently. So, if you remember, let me suck. All right? This is the best way to remember the causes of a gap acidosis. All right? And the gap has to be over 12. 12 is normal plus or minus 2. So if you let me suck, you'll be able to remember this. L is lactic acidosis. Methanol, ethanol, ethylene glycol, salicylate, uremia, ketoacidosis. These are the 6 most common ones. And the story will be obvious. If the person hasn't been breathing they're hypooxygenated. All right, that's what gives you lactic acidosis. That is the fastest way to make lactic acid, if your muscles and organs aren't getting oxygen. If they ingested something, the story is about an ingestion. You want to look at one of these guys. They'll make it very obvious what it is. They took too many pills. An empty pill bottle was found next to them. You got to take salicylate. If they have kidney failure and their bleeding line is like 150, all right, they probably have it from this. If they're diabetic, they come in with a sugar of 720. That's what they have, all right? They're not going to ask you, mud piles, peraldehyde, isoniazide, iron, all these other ones is never on the test. I don't even know where you find peraldehyde, but it's not on the test, so don't even remember that. Now, in real life, I always throw an R on there. Let me sucker, okay? Because rhabdomyolysis does give you a gap acidosis. And the myoglobin will be high, and they'll be peeing out red urine. It's not blood. The UVA, the urine dip will dip for blood, but they don't have red cells on the micro. It's myoglobin that's making it dip positive, all right? So if there's a urine dip and it's positive for blood, but there's no RBCs, it's not blood, it's myoglobin. And you got to give them tons of fluid and tons of bicarb and flush them out. So the last thing we'll talk about is heart failure, and then we'll get out of here. So there's two kinds of heart failure, right? There's systolic. It's all poor forward flow. It all comes down to your heart output is low, not enough forward flow. Either you're not squeezing hard enough, or you're not relaxing enough to fill up. So if your heart doesn't relax well, you may be injecting 80%, but it's not relaxing enough to fill anything. So your forward flow goes down. If your EF is like 10, you're not pushing anything forward anyways because your heart is weak. So these are the two kinds of heart failure. Everyone with systolic heart failure has diastolic heart failure. You cannot have one without the other. But these guys, their definition is they have a normal EF, it's just that they're not relaxing enough to push anything out. So the causes, you can all read about these MIs, infections, viruses, who knows, RV, infarcts, a lot of things cause it. Toxins, alcohol is a common one. But 50% of the time, we have no idea. Idiopathic means the patient has pathology and the doctor's an idiot, right? Idiopathic. So most of the time we don't even know. Now there are 3 drugs that are proven to improve mortality in heart failure, right? ACEs, beta blockers, and aldosterone antagonists. Nothing else improves mortality. They may ask you, they present a case of somebody with heart failure and they say, which of these drugs is the best choice? And they'll give you nitrates, digoxin, diuretics, furosemide, whatever. But they want you to pick the one that improves mortality. And it would be one of these, beta blocker, aldosterone, or an ACE. All right, now digoxin is kind of tricky. Digoxin makes your heart squeeze stronger, but does not improve mortality at all. It keeps them out of the hospital and it keeps them symptom-free. So remember that. Now I will tell you that all these other things are very, very important. A low sodium diet makes a big difference. The whole point about aldosterone is it makes you dump sodium. Exercise, very, very important. They have to check daily weights. If you gain a pound or more overnight, and you should counsel patients to do this, so keep them out of the hospital. If you gain a pound overnight, did you gain a pound of fat or water? You can't gain a pound of fat overnight. I don't care what you eat or do. There's no way to do that. So they will take an extra Lasix that day. All right? Pressure stockings help. You cannot, somebody has pitting edema in their legs. All the Lasix in the world is not going to get that out of there. All right? You need some kind of pressure on their legs so that the fluid can get into their vasculature so that the Lasix can get it out of there. All right? So that's what you have to do. You got to do this. Now, you have to relieve ischemia. Guy comes in last week saying, feels short of breath, you check his echo, his EF is 55. Cool. Comes back a week later, short of breath, check it, EF is 25. Okay, he probably had a heart attack. So we have to go in and open up whatever arteries got blocked. And the EF can recover over time, especially if we put them on all the right medications. They may need anticoagulation if their EF is so bad that blood is pooling. They may need a biventricular pacer if their QRS is way too wide. They do need if their EF is less than 35, they do need a defibrillator. People with EF less than 35 are at very high risk of sudden cardiac death. They go into VTAC, Lipid, whatever. Defibrillators get you out of that. So they're all, if their EF is less than 35, they need that. Diastolic heart failure. No one really knows what to do with diastolic heart failure. All right? If anybody tells you they know the answer, they should be winning like a Nobel Prize or something. But we do know some things that kind of help. Diurese them for volume overload. Slow their heart rate down if it's too high. Get their blood pressure under control. And relieve ischemia. If they've had a heart attack or something, you open that up. But no one really knows much more than that. I will tell you here, for heart failure, if you want like a summary statement on how to treat heart failure, it's get their blood pressure down to as low as humanly possible without them passing out. All right? Their heart barely pumps. If you can reduce that resistance in their arteries somehow, that will give their heart a break. Their heart can just pump a little bit and it will come out. So you got to reduce the systemic vascular resistance, get their blood pressure to as low as possible so they're not passing out. That's really the treatment. And that's it. Do you guys have any questions? Any cardiac questions? Anyone? Well, good luck with your studying. I'm sure you guys will pass and do really well. If you have any questions, there are multiple ways to contact me, and you can ask me any questions you want. Thank you very much.